Good evening and welcome. We're thrilled to have you join us for Impact Melanoma's Melanoma Symposium for the spring of 2024. We are thrilled to have so many people engaged, and you're in for some really wonderful information tonight. And you will have an opportunity after Dr. Lawrence's presentation to have some time for Q&A. So I'll ask you during the presentation, feel free to put questions in the chat, and we'll make sure to get to your questions. So I want to tell you first a bit about Impact Melanoma, because we have people from all over the country tonight, and we want to make sure that everyone has an opportunity to know about the good work that we're doing here at Impact Melanoma. The very fun part of this is that this symposium is the beginning part of our 25th anniversary celebration. We've been providing public awareness, education, and support now for 25 years to communities now all over the country. We started as a very small organization in Massachusetts in 1999, and today we are in all of the states in the United States, as well as now Puerto Rico. So we're really thrilled to share with you tonight our mission. Our mission is really to reduce the risk of skin cancer and melanoma. And as part of our mission, to provide support to melanoma patients and their families. And one of the ways that we do that is through our support groups. And I'm going to introduce you in a minute to Kelly Braga, who is the manager of our support services program, and she'll be able to share more about that with you. So as I said, Impact's been around for 25 years. The major project that we have in the communities right now is our sunscreen dispenser program called Practice Safe Skin. And in this program, we have an opportunity to partner with people all over the country in bringing not only sunscreen, but other sun protective clothing and educational programs into your communities. So, and then also Shade. Shade is our latest initiative because we understand that it is very difficult in some places to be outside because there is no shade. And we know that shade is very important in what we need to do to protect ourselves in the sun. So we know that there are people struggling all over the country with this diagnosis, and we want to be there to be caregivers, providers, and really to support our caregivers as well. So I'm going to introduce Kelly Braga. Kelly is, as I said, the manager of our support services team. And for some of you in the audience, you recognize Kelly as your support group leader. So I'm going to turn this over to Kelly, who will tell you a bit more about what she does. I'm also going to ask everybody to make sure that you're muted as we move forward. So thank you so much. And please remember to put your questions, any questions, in the chat, and we'll do our best to get to all of them. So, hey, Kelly.
Hey there. So thank you so much, Deb, for the introduction. It's really wonderful to be here tonight, and I'm so thrilled to know that many of the folks that I work with in our support groups are tuned in this evening for this important discussion. So as Deb mentioned, I'm Kelly Braga. I'm the support services manager for Impact Melanoma. We have, as part of our programs, we have a national support group specific to patients that meets on the first Monday of the month at 12:30 Eastern Time. It's a virtual group. In addition, we have a specific group for caregivers that meets on the second Monday of the month at 12:30 Eastern Time. So that's available to anyone nationwide. And in addition to that, we have 2 local support groups in Massachusetts as well. More information about all of our support services can be found on our website under the support tab. It has a lot more information on there. In addition, my contact information is on there. So if it's something that you're wanting to hear a little bit more about, have questions about, I please encourage you to reach out to me, and I'm happy to engage in a dialogue with you and talk to you a little bit more about our groups. In addition to our support groups, we also have our Billy's Buddies program, which is a peer mentoring program where we train melanoma survivors with patients that are looking to get connected that are more newly diagnosed. So that's a more one-on-one peer support group, and more information also can be found on our website under the support tab. So again, thank you all for being here, and please reach out with any additional questions, or if you're interested in getting involved, participating in any of our groups or our Billy's Buddies program. Thank you.
Thanks so much, Kelly. Please, if these groups could be helpful for you, please check them out. We have lots of people from around the country, and it's always an easier road when you do it with someone else. So after this, I think we're going to go right into our topic for the evening. And I want to introduce Dr. Don Lawrence. Dr. Lawrence is the clinical director at the Melanoma Center at Massachusetts General Hospital and Harvard Medical School. He has 30 years of experience caring for patients and with melanoma. His research interests includes novel immunotherapy treatments, specifically cellular therapies such as tumor-infiltrating lymphocytes. He is a member of the Severe Immunotherapy Complications Service at Mass General, focusing on optimal treatment and supportive care for patients experiencing side effects from immunotherapy. Dr. Lawrence is a native New Yorker, but has lived in the Boston area for more than half of his life. He says it's beginning to feel like home. So with that, I'd love to introduce Dr. Don Lawrence. And what I will say, one last thing before I turn it over to Don, is that one of the reasons we love to work with Dr. Lawrence is that what we hear from all of his patients is that his kindness and caring and focus on the human issues that people are dealing with sets him apart from others. So I thank you for that, Dawn, because you make such a difference in the lives of patients. And with that, I'm going to turn over the science to you, my friend.
Thank you. Well, we'll get to the science, but first of all, happy birthday to Impact Melanoma. I feel like
Thank
we
you.
should have a cake with 25 candles.
We
And
will on October
okay.
18th, Dawn.
Oh, good. That's right. Okay. So, but you and I go back to the days of the New England Melanoma Foundation, and it's just the growth and what you've done over the last couple of decades has really been amazing. And just you are the leaders in education and prevention of skin cancer. So I see a lot of friends actually here on the meeting. There are people from across the country as well, from what I understand. So welcome. And with that, I will share my screen and we'll get started. Okay. Is that visible? I'm never quite
Yes,
sure.
very
Okay.
good.
All right. So we'll get to tumor infiltrating lymphocytes, which I am really excited about, more excited than anything in the past decade, I would say. But we're going to take a kind of circuitous route to get there. And that's going to start really with a very, very old story or problem that has very recently been elucidated by my colleague David Fisher at MGH. He's the chief of dermatology and one of the leading melanoma biologists in the world, an incredibly creative thinker. Oops, why am I not able to advance? All right, I'm gonna have to go out and go in again. see if that works.
It
Okay,
does.
so the question is, why do people like to tan? Why is it such a challenge for impact melanoma, public health, primary care physicians, everyone to make this message clear and change behaviors? And so is it vanity that people want to be tan? Is it ignorance, stupidity, all of the above? It turns out that there is a compelling biological reason why people like to tan. It's biology. It's built into us on an evolutionary basis. I do believe in evolution, so if there's anyone here who objects to that, that you might want to log off now. So it turns out that, like sunflowers, which turn their face to the sun, people are also heliotropes. They seek out sun for some very good, well, compelling reasons. And it's biology, but it's biology that is, I think, easy to explain. At least it's easy for me to understand, and therefore I hope easy for me to explain. So this is a brief detour into the biology, and it all goes back to the tanning response. So, of course, we know that it feels good to lie in the sun, and the effects of lying in the sun are that you get a tan. The process that starts the tanning is exposure to UV radiation, which causes DNA damage. And just to pause for a minute there, it's important to point out that you cannot tan without causing some DNA damage in your skin. The two are intimately connected. You can't have one without the other. So anyone who thinks other cells in the skin, so-called keratinocytes or squamous cells, and they produce a substance called POMC, or pro-opiomelanocortin, which is a mouthful. But this is a sort of locally acting hormone, and it exits the cell, and then it gets cleaved, it gets cut into two parts. One is a molecule called melanocyte stimulating hormone. As the name implies, this goes to the melanocytes. It stimulates them to produce pigment, to produce melanin, and that is the tan. However, the other half, this is really amazing, is beta endorphin. And beta endorphin is what's called an endogenous opioid. And it goes throughout the body, and it sits on the same receptors that would be occupied by morphine or heroin. So this is, it's an opioid. It's an endogenous, meaning self-produced opioid. And this explains so much cultural and social behavior and why people seek out the sun. They're actually getting high. However, they're also getting addicted. So here we see the pale man who is unhappy. He goes in the sun, his DNA is damaged. He may get skin cancer later, but this damage response leads to pigment production, so he gets a tan. And he's also now happy because he's high. He's got beta endorphin running around in his system. So we know that it feels good to lie in the sun, and this is why. And it is an addictive behavior. UV radiation is, it's a substance that people can abuse. And in mouse models, mice display physical dependence after UV exposure, meaning that if you put them in a cage and allow them to press a lever to give themselves more and more UV exposure, they will do that to the exclusion of eating and drinking and everything else, the same way they would if they were getting doses of morphine. Uh, in humans, this is certainly not like getting a dose of heroin, but it does lead to habitual tanning. And also, it's thought this plays a role in seasonal affective disorder, which may be a withdrawal from the endogenous opioid when winter comes around. So it's this is why it's so hard to fight with people about their sunbathing habits. Now, why should this system exist? And we think this has been built into us, from the early days of mankind. If anyone can tell me who this person is when we open up the chat later, or you can put it in the chat now, then I will bow to you and offer you a gift. But I'll tell you anyway, he is Charles Darwin. And although he did not think at all about sun exposure and beta endorphin and all this stuff, I think the origin of this phenomenon is evolutionary, in that when we lived in caves, and there had to be a good reason to go outside and uh, forage or hunt and gather among the saber-toothed tigers. It was safer to live in your cave. If you did that, however, if you didn't get at least your 15 minutes of sun exposure per day, you would get rickets, vitamin D deficiency, and you would die before reaching a reproductive age. And so that part of the population who didn't seek out the sun would not reproduce. And this creates a physiologic reward for seeking out the sun, at least for part of the day. Now, we know we don't need to go out in the sun now to get our vitamin D, but there was no other way if you were a caveman or cave woman. So I find this such a compelling story. I try to tell it to as many people as I can. I wanted to share that before we got to the other substance of the talk, which again, we'll get around to TIL therapy. It's really critical, though, to take a large step backwards, not to ancient prehistoric times, but really just to about 20 years ago or less, and look at where we were with melanoma and where we have come, and to put into context where we are going. So these curves here, I hope no one is sort of intimidated by these things. These are called Kaplan-Meier curves. And these are an essential part of how we analyze and look at the efficacy of our treatments. And very bluntly, they look at the number of patients alive over time, or the number of patients who are free of cancer over time. And so on the x-axis, you have time here in months, and on the y-axis, you have the percentage of people surviving. So this goes back to a trial published in 2008 by an old colleague, Mike Atkins, and this looked at a very complex multi-agent chemotherapy regimen with or without what was then considered state-of-the-art immunotherapy, interleukin-2, and interferon. And the first thing to notice is that the with and without the immunotherapy, the curves are entirely the same. People are passing away at a rapid rate. And once you get out to 20 months or so, you have only about 20% of people still alive. And up till this time, and really up to the next slide I'll show, there was no treatment that had ever demonstrated an ability to prolong life in melanoma, much less cure it after it had spread internally. But this is just an example of the futility, and there are many other examples. This happens to be a striking one because this regimen was so toxic. It probably was the most emetogenic, meaning nauseating, treatment I've ever given, and I'm so thrilled never to have to give it again. So, but to also to put in perspective where we are now and where we are going, I do think we have to take another short scientific detour and talk about really the fundamentals underlying cancer immunotherapy. And there are some paradoxes here that are worth thinking about. And the first question is, well, why do we have an immune system? Is it to prevent cancer, to treat cancer? The answer is probably not. The immune system evolved, again, evolution, to fight off the scourges of mankind, bacterial infections, fungal, parasitic, viral infections, to allow people to survive to reproductive age. If your immune system doesn't do that, if it's deficient in some way, then you will not procreate and you will be selected out of the gene pool. So the people who survive at least that long are people whose immune systems are functional. That is the main project of the immune system. And the way it does that is by carefully distinguishing normal organs, normal tissue from something that it recognizes as foreign. So the immune system, you can think of it as kind of xenophobic. It doesn't like foreigners. And, so these proteins on the infectious invaders are recognized as from somewhere else and can be destroyed. So again, the question is, does your immune system care whether or not you get cancer? I think there's certainly some role in protecting from cancers, but most people who get cancer have intact immune systems, as far as we can tell. Many people ask me, well, I'm healthy, I never get sick. Why did I get this? Is there something deficient about my immune system? And the answer is no, as far as we can tell. Cancer can evolve despite a robust immune system because the immune system really didn't evolve to detect and eradicate cancer. And it's not a surprise, actually, because cancer cells, they are us. They are just about 100% similar to the rest of the cells in our body, but not quite. The emphasis is on almost. And so why would they be recognized as foreign and eliminated? And this led for decades to a lot of very brilliant people being skeptical about immunotherapy. How could you induce an immune response against essentially what is self tissue? But recent insights explain that. And it goes back to this this graphic, but looked at in a different way. So as I said, the first step in this process of tanning involves exposure to ultraviolet radiation, which causes DNA damage. And that is the key. We can forget about the tanning response and the beta endorphin for the moment and focus on DNA damage. And this damage makes cancer cells look different enough to the immune system that they can mount a response in many cases. In fact, in the majority of melanomas, there are enough mutations that some of them just randomly can be detected by the immune system. These are junk mutations. They're UV damage. They don't do anything to promote the growth of cancer. They're just sort of bystander damage, but they make the cell look funny to the immune system to the extent where the cells can be recognized by it. But if that's the case, then why does cancer grow at all if melanoma is full of these damaging mutations that make it look foreign? And the answer to that, and I promise we're getting to the end of the biology here, but the answer to that is that although the immune system, the T cells and other immune cells can recognize cancer cells as something foreign, something that doesn't belong there, they are sniffing it out, they are unable to attack and destroy it because the cancer itself is incredibly devious and smart. It erects barriers to the immune system. It makes itself invisible. It can even kill the immune cells that are trying to invade and kill it. So cancer cells actively ward off the immune response. If they didn't do that, there probably would not be a tumor there. So as a survival mechanism, they have adopted some of these natural interactions that the body uses to bring the immune system to a state of quiescence after a response to infection. The cancer cells use that to put the immune system to sleep. And yeah, the key, this is a key breakthrough in general. And there are, well, going back to the last slide, I hope no one tried to memorize this or take a picture. I don't really understand it all myself, but the point is that there are many mechanisms of immune suppression in a tumor. And amazingly, the identification of two of these key mechanisms has led to the development of drugs that can take the brakes off of the immune system and allow it to not only recognize cancer, but do something about it, attack and kill tumor cells. And so the two that we really know the most about are the PD-1 and PD-L1 interaction, which the tumor cells use to ward off T cells, to even to delete them, to kill them, and something called CTLA-4, which also is called, it's another immune checkpoint, as it's called, something that puts the immune system to rest. So these prevent immune cells from attacking tumor cells. Two key mechanisms, but certainly by far not the only ones. So our best drugs, which probably many of you know about and have firsthand experience with, or have family members who have received them, are these PD-1 antibodies, nivolumab and pembrolizumab, which take this PD-1 brake off the immune system, and the drug ipilimumab, which acts on the CTLA-4 brake, releasing that and allowing the immune response to proceed. So that was a preface to explain what has led to the enormous progress in the last 15 years or so, and the survival of many patients with very advanced melanoma. So ipilimumab, the CTLA-4 blocking antibody, was the first of this class of drugs to be developed. And although this Kaplan-Meier curve doesn't look that impressive, this is actually based on a huge number of patients from multiple clinical trials, almost 5,000 patients. And while only about 20% of people did well for 3 years, if you did, then the chance of continuing to do well with no recurrence of melanoma and surviving as the bottom line was really great. So we look at this flattening of the curve, as we call it. That is the goal we want to achieve. And so ipilimumab was, despite a relatively low objective shrinkage rate of tumors, it leads to prolonged survival and we think cure in a minority of people, about 20%. So the goal is to achieve this plateau in the survival curve, but also to push it up higher and higher so that 30, 40, 50% of people will, will respond durably. And that, in fact, is what we've seen with subsequent the PD-1 drugs and combinations of immunotherapy drugs. And to skip over a few hundred clinical trials, I think this is really a benchmark trial in melanoma that compared ipilimumab, and again, you can see the long-term survival rate out to 6.5 years, coming in at around the same rate, around 23%. And then with the PD-1 antibody nivolumab alone, the survival rate goes up to 42%. And with the combination of nivolumab and ipilimumab, it goes goes up to 49%. Now, I should say, we don't conclude, at least I do not conclude from this, that the combination is always better than the single drug. But certainly we don't use IPI anymore as first-line treatment based on this. It's clearly inferior. This difference between the combination arm and the Nivo arm is actually not statistically significant, and there are people who interpret this different ways, but not everyone needs the combination therapy, which has far more side effects. That's for another talk. I'd be glad to pontificate about the side effects of these treatments for a very long time. It's still highly problematic. So that's where we are now. Really remarkable, close to 50% durable response rate. These people have been off therapy for most of this period of time. At most, we typically give a year of treatment, uh, unless people run into serious side effects, and then we stop earlier. And then we discontinue the treatment. And in most cases, people who are doing well at the 1 year point continue to do well. There is some drop off, but it's a relatively small number of people who will have recurrences after the 1 year point, and certainly after the 3 or 5 year point. I am convinced that we are curing people with these drugs and combinations of drugs. Now, this is a clinical trial. This was highly selected patients, and this is, the real world is not reflected necessarily in this number. People who are older, sicker, have multiple medical problems, come in with extremely advanced cancer. So we're probably not hitting the 50% mark in the real world, but it's close. It's close. And when I meet a patient, I do tell them that the goal of their treatment is long-term remission, and we think that it is cure. Uh, this is almost unique among solid tumors that we can even speak about the possibility of cure. So absolutely flabbergasting revolution in the treatment of melanoma, which used to be probably one of the worst cancers. It was called the disease that gave cancer a bad name. It is now one of the most treatable of solid tumors. Uh, and just as an illustration of the power of this treatment, we were uncertain and somewhat skeptical about whether these immunotherapy treatments would work in the brain, because the brain it's called a sanctuary site, meaning that the immune system doesn't get in there very well. And so it was really an open question as to what we would do with the people with brain metastases, which are unfortunately extremely common in melanoma. So this person I met a little under 3 years ago, and he came in with these very advanced brain metastases. You don't have to be a radiologist to pick these out. And as you can imagine, he wasn't feeling so hot at the time. Neurologic stroke-like problems, nausea, headache. So the first thing that was done is one of my neurosurgery colleagues removed these tumors just to relieve symptoms and also to get him off of steroids, which are immunosuppressive. They're used to reduce the swelling around these tumors, but they really inhibit the immune response and the likelihood of benefit from immunotherapy. So this we would call a debulking. You certainly didn't remove everything, but these 3 huge tumors were removed surgically. But as you see from the panel on the left, even after that surgery and a different view of a different part of the brain, there were still large tumors, these big white balls here, left over. So the patients started combination IPI and Nivo, received 4 cycles, then moved on to our standard maintenance therapy with nivolumab. And essentially, this is a complete response in the brain. You can still see a wisp of the contrast material in some of these areas, but the tumors are gone, and the patient continues to do well with no recurrence through today. So just an illustration of the power of this treatment. And we see this time and again. It's not that rare an occurrence. But what about the 50% or more of people who do not benefit from our current immunotherapy drugs? And it's been really frustrating that there have been no major breakthroughs that have improved survival rates for those people. There have been incremental advances, but nothing close to the order of magnitude, multiple orders of magnitude that we saw with the checkpoint inhibitor drugs. So we've been at something of a standstill for the last several years and really not having a successful treatment for people who do not respond to IPI and Nivo and Pembro. So that's where tumor infiltrating lymphocyte therapy comes in. And this is also immunotherapy, but of an entirely different kind. So I'll walk you through what this is, what this means, how we use it, and what the results look like so far. So it turns out that within almost all tumors, and certainly within almost all melanomas, there are immune cells that are infiltrating, invading the tumor, hence the name tumor infiltrating lymphocytes. Lymphocytes are immune cells. Why are they there? Well, going back to what I discussed about the cancer cells looking somehow foreign, different from normal self, these lymphocytes are sniffing out something that doesn't look right about the tumor, that looks different from normal self. Otherwise, they wouldn't be there. But they're clearly not doing a good job of attacking the tumor cells. Otherwise, the tumor wouldn't be there. So they are frozen in place. They are subject to the immunosuppressive forces that are exerted by the tumor itself, and they are unable, despite recognizing the tumor cells as foreign, of doing anything about it. So what do? So when we take these cells out of the tumor, they wake up and they become more active, and we obtain them by surgically removing a tumor. The surgery is not to provide any direct benefit for the patient. It's strictly to obtain these potentially powerful cells that are recognizing the melanoma. And so the tumor is then dissolved, and we're left with the immune cells. And then those cells are grown in a laboratory. They're multiplied to huge numbers, billions of cells. And that is, in essence, our living drug, the tumor infiltrating lymphocytes. But it's not the sheer numbers that are the only important factor. It's also this process of removing them from the immunosuppressive tumor microenvironment that allows them to become more activated. So you have this army of melanoma fighting cells that is now reawakened and potentially better able to re-infiltrate the tumor and kill it. So after these cells are prepared, the process, if you just give them to a patient through an IV, nothing happens. The rest of your immune system, this is my simplistic way of thinking about it, the rest of your immune system looks at these funny cells and says, what are you doing here? And it basically gets rid of them. They don't last in the circulation. They don't home back into the tumor. In order to get them to do that, the patient needs to get very high doses of chemotherapy. Again, not to treat the cancer, but to clear a path in the immune system, or make room in the immune system for these new cells. Obviously, it's not really a physical space that's created, but or another way to think about it is creating a fertile ground for them to engraft. So high-dose chemotherapy given over 5 days typically, and then the TIL cells are reinfused. We have a bag of them, and like a blood transfusion, they go in through an IV. And then the patient gets several doses of a drug, a notorious drug called interleukin-2, which has a lot of side effects. And we used to use it by itself in the old days at very high doses, much more than we would now give as part of the TIL process. And I still have patients who are treated with interleukin-2 as a single drug 10, 15 years ago or more who had durable remissions, but it was a very small percentage. It was fewer than 10%. So we really don't use that anymore. In this context, it's used to light a fire under the TIL cells. It's a T cell growth factor that makes the cells multiply and activates them. So we've gotten these cells that were not effective when they were in the tumor originally at killing it. And so why does it work? Well, we think it works because they have been released from immunosuppression and also because there are large numbers of them. So this graphically illustrates the TIL process, starting with this guy on the left who has a tumor excised. The tumor is dissolved. The immune cells are grown actually with interleukin-2 in a petri dish. And then they are put in bags and shipped back to the treating hospital or made at the treating hospital. And then the chemo and then the TIL cells are infused in, and then the interleukin-2. And then the patient feels miserable and stays in the hospital for a week or two afterwards. The chemo is really quite intense. The interleukin-2 is not easy. The cells themselves actually have few side effects, occasional fevers and allergic type reactions. It's the chemo and the interleukin-2 that are problematic. And the consequence of the chemo universally is that the blood counts drop to very, very low levels, and there is a risk of infection. So these patients need very careful monitoring in the hospital until their blood counts recover. So the first cellular therapy for any solid tumor was approved by the FDA in February of 2024, and this is the drug or cellular product lifileucel, also known as Amtagvi, which I can't get used to saying. So this was an enormous addition potentially to our list of things that we can offer patients. And the study that led to the adoption to the FDA approval was a relatively small one, but it was in patients for whom no other treatment had worked. All those checkpoint inhibitors, targeted therapy, if their melanoma had a BRAF mutation, nothing. And a little over 31% of these people will have shrinkage of their tumors. But if it's just transient shrinkage, it just wouldn't be worth going through this. So again, we look at the survival curves, and although most patients do not respond,
Something with the audio, his audio. Don't do anything. It's not us.
I think somebody came off mute. But in any case, there is, we think, a cure rate because there have been many prior trials of TIL therapy at the National Cancer Institute and elsewhere that show similar, if even better, responses in patients who have received less therapy prior to their TIL treatment. So just illustration, we always pick our superstars to describe, but I treated a 62-year-old woman with metastatic anorectal melanoma. You may ask why melanoma starts in the rectum, and that's a mystery. Clearly, it's not from sun exposure. It's a different disease, but one that is actually very hard to treat and does not respond to conventional immunotherapy very well. So she underwent TIL therapy. Her day zero, the day of the infusion of TIL, was in November of 2022. And this is not as dramatic as the brain scan I showed you, but her scan prior to TIL therapy showed I'm not sure how well you can see this, but there are a number of small gray spots in her liver. This is her liver. And we can see that in her last scan, actually, she's had one subsequent to this. Those spots are gone. It was difficult treatment for her, but she recovered well. She's living a normal life and really with no evidence of cancer at this point. So this is an illustration of the potential for long-term remissions with our newest treatment. However, TIL is not for everyone. Side effects are very intense. It requires that a patient be in overall good health, good heart and lung function. Brain metastases in this case are really exclusionary. Unless they are well treated with surgery or radiation. And perhaps a major barrier with the current iteration of TIL is that usually it takes us a week or two to set up the surgery, to harvest the tumor. And then from that point, it takes 5 weeks for the cell to grow. And as any one of you know who's had a loved one with advanced melanoma or has had it themselves, this almost 2-month period is an infinity in this context. And so that is, really a barrier to treatment for many people. So I'll tell you a secret. It's an open secret among the professionals in this area, but lifileucel, this breakthrough therapy that was just approved by the FDA, is really an ancient and somewhat antiquated approach to cellular therapy. It really mimics what was done and pioneered by Steve Rosenberg at the National Cancer Institute decades ago. This was a seminal first paper, and it was, that you can see, it's published in 1988. So we've known for many, many years, decades, that this treatment can be effective for melanoma, leading to long-term remissions in some. So why now? Why are we now excited about it? Well, it's really because Iovance, the company that produces lifileucel, made this a treatment that can be given at other places. It was really only available at the NCI and a very few other centers because of just the enormous technology and the investment needed to grow your own TIL. So it's now an automated process. We remove the tumor. It gets shipped directly from our operating room to the Iovance processing facility. And then 5 weeks later, we get back a bag of TIL, and then we're ready to go. So it is a breakthrough. I don't want to minimize that, but it's more of a logistical breakthrough than it is a scientific breakthrough. But I also think it's just the tip of the iceberg. This is sort of ancient technology, and there are next generation TIL that are in clinical trials right now that are showing incredible results. They can be grown from much smaller amounts of tumors, potentially from biopsies rather than surgical specimens. They can be grown more rapidly. The growth techniques can enhance their activity. They can be genetically manipulated in a number of ways to make them more potent at fighting tumors. Some of them require lower doses of chemotherapy and lower doses or no interleukin-2. So this is going to make this approach much more accessible to many more patients. The rapidity with which the cells can be grown is critical, and in one of the trials we'll be opening, it's a 2-week period. That makes a huge difference. So this all goes back to this mysterious interaction between the immune system and a cancer cell. And we are, there have been so many people who have unraveled these mysteries over the decades, and some of the leading people in our institution are still working out the mysteries that remain as to how the immune system attacks, recognizes, and kills cancer, and also the mechanisms of resistance. why, when it doesn't work, does it not work? That's the frontier. And with that, I will stop, and I would be delighted to take questions. All right,
Thank
so
you so much, Dawn. That was really incredible. I've been around this universe for about 20 years, and when I first started, if you had a stage 3 diagnosis, then we were thinking, this patient's not going to make it. There's IL-2. They were so sick from treatment, but to look at what's happened in 20 years is just phenomenal. You just spent a half an hour giving people more hope than they probably thought they were going to have when they came into this talk tonight. So I'm really quite grateful
yeah,
for
I
you for
never
doing
thought I
that.
would see the day. So
I
it
know.
is so amazing. But I also know that there are so many people who did not make it. And,
Exactly.
heart goes out to them. I see some family members in the audience. They know who they are, patients who are so dear to us, for whom, nothing helped. And so we've still got a lot of work to do.
Right. So let's start taking some questions. You ready? Um,
I am.
uh, I'll start at the bottom and work up. Who's doing next generation TIL? Anybody specializing in metastatic uveal melanoma?
Yeah, so very good question. So it, in a world of a bad disease, melanoma, uveal was the worst
The
of the
worst.
worst. Really, nothing seemed to work. The checkpoint inhibitors, minimal activity, nothing we tried seemed to help. That has all changed in the last few years, and it's based on some fantastic science. And there is a drug that was approved by the FDA. It's not a home run, I would say. It's called tebentafusp or Kintrack, that
Ooh,
can
that was
really
very good, Dawn.
feel like that. So
Yeah, I
rolls,
like that.
and it's not a cure, but it clearly prolongs survival, and for many people, it's well tolerated. So it's a first step, and it's an immune therapy, and it points in the direction of other immune therapies, including cellular therapies that we think will have activity. So I can point you to the specific trials and who's sponsoring them. I mean, I don't get paid by any of these people. Let me just say that I'm not a paid consultant for anyone. But for example, there's a company called Immatics that is creating a very interesting next generation. It's actually a T cell engineered cell therapy, not strictly speaking a TIL. And it's targeted at a protein that is highly expressed on uveal melanoma, and it's shown activity in uveal melanoma. It's still very early, but there are other approaches also, targeted therapies. So it's a fast-moving field.
Thank you. Um, what about patients who have immunosuppressive conditions, except our example, like RA, are they TIL candidates?
Potentially, yes. So the checkpoint inhibitors are problematic for those people because they can cause a flare of autoimmune diseases like RA or MS or ulcerative colitis. So we can treat many of those people, but with a fair degree of trepidation. And so, but we try with our existing drugs when we can. Yeah, so but till it's interesting because it does not have the same kind of autoimmune toxicity that the checkpoint inhibitors do. And in fact, the chemotherapy that is given prior to the TIL is highly immunosuppressive and may actually have a beneficial effect for some of these autoimmune conditions. And we're still not using TIL as frontline therapy in anyone, but I think that's an area where it shows promise, as well as these mucosal melanomas, as in the case that I discussed, melanomas that we think do not respond as well to conventional therapy. And I think this is maybe getting to closer to frontline for those patients.
Thank you. There's a question about, are there any biomarkers that can predict which patients will respond?
Yeah, that is a fantastic question. And the answer really is no at this point. We are actively looking into that. I mean, it's despite the fact that this is a technology that's been around for decades, we really don't know much. I mean, it's not even clear whether the mechanism by which TIL cells kill melanoma is a conventional T cell mechanism or something unique. And the mechanisms of resistance are probably different than they are to other forms of immunotherapy. Even with the existing drugs, the Pembro and Nivo and so on, we don't have great biomarkers. We have some that are helpful. And until I would say we don't really know at this point how to predict who will respond.
Along with that question, Don, are patients in the hospital from the time of surgery until TIL treatment?
No, no. So they get surgery. We try to do the surgery as minimally invasively as possible with robotic or laparoscopic procedures, but we're pretty aggressive. Our surgeons will go into the liver or the lungs to retrieve a tumor if necessary, because it's so critical to get that reagent to create the drug. But patients usually recover from the surgery well. I always say minor surgery is surgery that happens to someone else, so this is not minor. But then the patient goes home and basically waits and waits and waits for 5 weeks for the lifileucel to be ready. And as I said, that's a long time to wait, and things can happen over that period of time. So that's a problem. We need to speed up the process.
Another question that came through is, what's the mortality rate of TIL? I understand that is quite high, which is a
Mhm.
concern considering still low percentages of patients achieving a complete remission.
Yeah, so it is actually reported to be around 7%. I cannot imagine really why that is. I think, even though these studies were largely done in places that had a lot of experience with cellular therapy, high-dose chemotherapy, interleukin-2, I think there was probably a learning curve, and I think the mortality rate should be close to zero. The main cause of serious side effects is the low blood counts and the risk for infection.
Mhm.
7% of people should not die from this treatment. It should be closer to, well, as close to zero as possible. And unlike the checkpoint inhibitors, where the side effects, the colitis and lung inflammation, all the itises can go on for weeks and months and require ongoing immunosuppression, the vast majority of the side effects from TIL are concentrated in the first 30 days of treatment. And after people go home from the hospital, they may not feel wonderful, but the chances of a severe side effect are actually quite low. And it's a one-time, I should stress, it's a one-time
One time.
treatment. We don't do this to people over and over again. That would be
Yeah, that
inhumane.
sounds really horrible.
Mhm. It
How
does
can
sound horrible.
how can we expand TIL therapy outside of academic centers so this treatment does not geographically exclude patients? That's a
Yeah,
big one, Dawn.
it's happening right now. Iovance I mean, we were one of the first centers to open at Mass General, but there were about 30 centers that were initially identified, most of them large academic centers, but distributed throughout the country. And now the plan is to open at a total of 70 centers. I think I
Wow.
am frankly concerned about this. This is not something you should try at home or do once or twice a year. You need to have, I mean, we were able to piggyback on a very well-oiled machine that does cell therapy of different sorts for other kinds of cancers, for lymphomas and multiple myeloma. They had the technology, the infrastructure, the expertise. They knew more than I ever will about the lymphodepleting chemotherapy. I know more about IL-2 than they will ever learn. So it was a good collaboration. I am worried that there will be serious problems as this is rolled out to other centers. I really think it needs to be done in centers of experience rather than, broadly at community hospitals or even smaller academic hospitals.
Thank you. That's really helpful. We'll take one more question. I think we're getting close to time. What can you tell us about the current status of RNA vaccines and how they might fit into current therapy?
I knew someone was going to ask that, so thank you for that. And of course, with minus 2 minutes to talk about this, it's hard to give an answer. But I think so. The mRNA vaccines use the same technology as the COVID vaccine, essentially injecting with RNA that creates a protein. In the case of the COVID vaccine, it's the spike protein, and it induces an immune response against that and therefore wards off COVID. The Moderna personalized cancer vaccines are really almost like science fiction in that they are tailor-made to each individual patient based on the mutations in their particular melanoma that are capable of inducing an immune response. So it really is truly individualized therapy. And there's good evidence now that they work. We haven't seen it in people with advanced melanoma, but in that context, as you were referring to, people with stage 3, high risk of recurrence, they do, it's pretty clear, the studies are not completed yet, but based on a large number of people, they enhance the activity of drugs like pembrolizumab to prevent recurrence. And this is just, the sky's the limit with this stuff. There are all kinds of other applications with the mRNA technology in combination with immunotherapy, with cellular therapy, with checkpoint inhibitors. I mean, it just boggles my mind that this exists and that we are going to be using it very soon. And we are doing those studies now.
Thank you so much, Don. This has been incredible. And I think people in this audience are feeling comforted tonight as a result of some of the hope that you've been able to share. I would like to invite people. Our next symposium will be on Thursday night, October 17th at the Harvard Medical School, and will also be streamed. And our discussion topic will be the melanoma vaccine. Dr. Lawrence will be back, and we'll also have a physician from Moderna to take part in this. And we're going to add a little piece on prevention to talk about a study that Impact's been working on for 2 years through the CDC with the Harvard School of Public Health, looking at sunscreen use in teenagers. So that alone is exciting. So I hope you'll be able to join us for that. Please go to our website. We are also going to have our 25th anniversary party on Friday, October 18th in Boston. We'd love to have you join us. And in the meantime, check out our website. Our programs are there. You can learn about what you can bring to your community. And within the next day or so, this presentation will also be on our support group page. So that if you have if you want to go back and look at something, you'll be able to do that and share it with anybody that you think could benefit by it. So thank you so much, Dr. Lawrence. And we're going to be thrilled to see you again in a few months.
Looking forward to it. And again, happy birthday, Impact.
Thank you
Thanks
so
everyone
much.
for
Thank you,
listening.
everyone. And
Great.
we hope to see you all again soon. Good night.